So before we go in, I'm actually going to mute everybody just so that everybody, and I'm going to unmute Ben. Can everybody still hear me? Thumbs up if you can still hear me. Okay.
Can you hear me?
I can hear Ben.
Good.
Yep. Perfect. And you guys still have the option to unmute yourself. If you want to ask a question or something, you can unmute yourself. There's also a location where it says below, where it says chat, that if you want to ask a question in chat, either I can ask a question to Ben, or we have a couple of us on here that can answer that question as well too. So I just want to introduce Dr. Sutter. Dr. Sutter has been practicing since 2002, 2005. I was close.
Yeah.
On there. He's got a couple of fellowships with AGD, with Las Vegas Institute, and with ICMO out there. And I consider Dr. Sutter a TScan master. And for those of you who are Star Wars fans, if you look at the masters in Star Wars, he's definitely not Yoda. There's only one Yoda here, and that would be Robert Kirstein, who's actually on the line here. If I were to give Ben a Star Wars character, it would be Obi-Wan Kenobi, which kind of makes sense because his first name is Ben, right? So
I can take that.
without any further ado, Ben, it's all yours.
Perfect. So let's just jump right in. Let me see. Sharing screen. Okay, so what you should be looking at is my TScan software menu. I've got my my victim that we're going to record on today. A couple of settings that I like. I'm just going to show y'all. Move this down. Let's see where I can see it. I keep getting Zoom windows popping up. Okay, go down to, so you'll find this menu if you'll make a note to go under edit and then user settings and then click on advanced. I like to click on turbo scanning speed. I like to use this. It actually records in increments of 3/1000ths of a second. So you'll get more data, which is what we're all about anyway. I like to click on show all excursives in quadrant view. That way, when you go up and you select, you save a scan as right or left excursive, it's going to put it in quad view for you. And then the last one is use triggered scan start. Turn that off. If that's checked, get rid of that. Basically what that feature does is it won't start recording for you. It'll be charged and ready to go until your patient starts to bite down onto the sensor, but you'll lose those first little window panes of data. So turn that off. And so that's it. You're going to turn on turbo, turn off triggered scan start, and turn on show all excursives in quadrant view. And it may ask you okay or save or continue. Okay, so let me get Miss Ashley. Hey, Ash. Here she comes. Okay. So let me just make sure. What's that? No, you'll sit in this chair. I'm going to stand. Let me just make sure that. Good. Okay. So can you see me on video? Okay, perfect. Go ahead and have a seat. So I've already got her data loaded up. Face the camera. Scoot up a little bit. Perfect. Excellent. All right. So what I try to get doctors to do is to not to come from the front like this with the TScan, but rather stand behind them like you're going to take an impression, all right? And you keep your eye on the screen while you're recording, so you'll see what TScan is recording in real time. So go ahead and open, and you're just going to tell the patient to relax their cheeks, because a lot of times they'll try to open really wide for you, and what you're doing with that is you're tightening the cheek muscles. You don't want to do that. And then this little sensor here, this little stabilizer, you're going to rest in between the front two teeth, actually contact the front two teeth. So that gives you a repeatable position, okay? So let's do this. Good. Go ahead and bite down. Good, and open. I'm going to adjust my sensitivity. Bite down and open. Good. Bite and hold and open. Bite and hold and open. Bite and hold and open. Good. So you just saw me do a multi-bite, and I had her bite 3 times into the sensor. I like to do 3 because the first time usually somebody may not know what they're biting into, and they're a little tentative about crushing the sensor. And if there's a tiebreaker, or if you have 2 different bites, you have one that'll be a tiebreaker. That doesn't really happen all that often, but it's good to make sure you have repetitive data. So I'm using the Novus handle. Some of you may have the Evolution, but the nice thing about the Novus, you hit the record button, it cycles up a new scan for you. And what we're going to do on this scan is have her bite and crush, hold the teeth together, and then slide to the right. And then the third one, we'll have her do the same thing, but to the left. So you want to coach the patient, just tell her, keep your teeth together, but when you slide to the right, don't open and then move. Just let the teeth slide across each other, okay? And that'll show us working and non-working interferences. Good. Bite and hold, shift right, and open. Good. And I'm going to leave this just in place. We'll go right to bite and hold, shift left, and open. Good. All right, I'm going to let you go. Thank you, Ashley. You did really good. Okay. So okay, can you guys see the TScan data?
Yes.
In the background? Okay, good. So, good. I'm going to go ahead and save this as a multi-bite because that's what it is. We have 3 bites that we're going to be looking at. This is a right lateral, and you can see that when I selected right lateral movement, it broke the screen up into quadrants for us, okay? Since we're going to the right, I want to know where the most distal point on my canine is, okay? And that would be here. So I'm separating the data between our premolar and our canine. So that's going to make this down here our forced time graph accurate. So I'll save that. Good. And then we'll look at the left side. And good. We're broken up into quadrants again. So let's just kind of move and see. Looks like we're going to move our bar to about right there. So now all our data is accurate. That took me, I don't know, 2.5 minutes to get all of this ready for us to go over, okay? Any questions so far? No, all right. So obviously, you know, this is our dental arch form. you'll notice that she's heavy to the left by 64%, right, to 36. Something to note is we have a tooth missing. So she had extraction ortho done on the right side, but not on the left. So we have got 5, and I think 28 are removed, and they closed up that space. So it's going to be a challenge to get her exactly 50-50, and that's not really a goal. 5 percentage points to the right and left is really clinically relevant, okay? And then, of course, all the numbers on the inside of the arch tells me the percentage of bite force on that individual tooth. So kind of our one outlier is tooth number 14, and the opposing, she's got 1/4 of her bite on that one tooth. So we'll be taking care of that in short order next week for sure. The other thing that's important is this cursor is our center of force icon, which takes into account the average or the summation of all of these data points. And it works much like a bubble in a level. So it goes right and left and front and back. And our target zone is this white oval with the crosshairs here. So she is posterior and to the left of where we would like her to be ideally. Let's see if I can move this out of the way. Yes, good. Something we haven't talked about, and I really couldn't even see my screen when I was recording her because part of the Zoom software was blocking the TScan software, is you want, when you set your settings, and you saw me doing that in the beginning, I took a test bite with her before I recorded, and we adjusted the sensitivity. And you want 2 to 3 pinks is a good setting. You know, you don't want too many pinks because it really doesn't tell you. You'll have. It's like listening to music that's too loud. It's good information, but you really can't tell anything. You can't see the spectrum of high to low as well. Obviously, you don't want it to all be blue either, because then you'll think it's all low. So somewhere in between, and what's been published is 2 to 3 pinks when you take your recording is kind of the standard. This is a 3D window, obviously. It's the same exact data as this guy here, and down here we have our spectrum. So generally speaking, I think most dentists get the right-left balance and too much force on one tooth. That's almost intuitive. The other thing that TScan gives us is timing. And in my world, timing absolutely trumps bite force like 80 to 90% of the time. So even though you can't get her dialed in, having her spend the least amount of time on the posterior teeth is going to benefit her. Now, she is a migraine patient, and I haven't checked her bite in a while, and this is not really acceptable by my standards, so we're going to do some revision. But it's good because it gives us something to talk about that's really not kind of, the norm. Okay, so most people grab this pretty easily. When I bought my TScan, and I think it was in 2008, I paid attention to this primarily, and these colors. I had no idea what this was, what these numbers are, and down here had no clue what this time force graph does. So, and I operated like this for a period of probably 5 to 6 years before I actually had Youre come to my office and actually spend the day with me because I needed to get more out of this. So let's go over this down here, because this is the working end of your data. This is good, but this tells you a lot more about function. So right here you have the machine is recording, but the teeth aren't engaged, okay? So you have 0 force. And then as the patient bites into the sensor, force goes up. So you can see what happens is she bites hard, releases, and then goes back up to bite again. And she does the same thing here, bite hard, release, and then tries to hold a good clinch for us. Same thing here. So we're getting a consistent profile across all 3 bites, okay? Now, what are A, B, C, and D lines? And why are they labeled 1, 2, and 3? Well, the numbers are easy enough because this is your first bite, this is your second, and this is your third. The A line is first tooth contact, okay? So if we bring our sensor or our cursor over to that first tooth contact, it'll reveal to us that this is probably our first tooth contact, and this might just be the sensor folding. So as she bites harder into the sensor, we'll see other teeth coming into contact, right? But she really doesn't have bilateral simultaneity, although she's not too far off. So what do I mean by that? It's just both teeth touching at the same time. So you can see the order of some of these teeth, you know, coming in contact with each other. And then generally speaking, B tends to be about 80% of your bite force, which we're hitting it right here just barely. And then we hit it here and we hit it again here. Then there's a sustained clench, where she tries to clench, and then we go the opposite direction. So C, the sensor is telling the machine that we're backing off of force, and then D is our last tooth touching, okay? And all of this is measured in seconds. So if you ever really wanted to know what these numbers are, it's the time in between A and B, or occlusion, the time it takes for occlusion to occur, and then C and D is the time it takes for disclusion to occur, all right? So here we're just bringing the teeth together and then having her open, all right? Okay. And then what we'll do is we'll go to right lateral. Now, instead of having just 2 lines down here that are green and red, since I'm in quadrant view, these colors coordinate with these numbers that you see in all 4 quadrants, okay? So in someone that has anterior protected occlusion, when they go into an excursive movement, what you should see is this cursor comes up to the red quadrant, and down here the graph looks like all of the colors go down and you would see the red go up.
Hey, Ben.
Yep.
Could you just explain the tail on the center of force trajectory, please? Someone had a question on that.
Yeah, so if I rewind our movie, what's going to happen is the center of force icon is going to rewind back to the beginning of the first tooth contact, okay? So basically what that tells you is where you've been, right? And so I was going to get to that a little bit more when we had more data to look at, but you can see anywhere this cursor goes, it's going to leave a snail trail in the garden, right? When it rains, you wake up the next morning, you can't see the snails, but you see where they all were. So we can tell that as she makes a right movement, she, first of all, you see her going back to the posterior right here, and then the anterior starts to engage about right here. But she has still pretty significant interferences on the right side. So ideally, you want this to come up, you know, in a straight diagonal line. That doesn't always happen, but so we see our disclusion time between C and D is 0.50, and actually the D line should be moved to about right here. So I'm making a corrective movement because this is 100% all the way across from D to the end. And so to get a good actual time generated, you have to correct C and D. That takes a little just time to work with it and master that. But the software puts C and D in a good approximation of where things should be, and I'd probably correct the B to be right here. Okay, so knowing that when she goes to the right, we have some non-working interferences on the left, and we have group function on the working side, right? So looking at the left hand side, I'd probably move that to about right there. She's slow to go to the left. Actually, maybe even. So here she's sustaining and then starts to move about right here. Yep. Good. All right. So let's just go through the same workflow. So again, she's 60-40. Again, 5% variance is accepted. I've got 3 pink, 1, 2, 3 on my sensitivity setting. That's certainly ideal. And then I want to look at what teeth touch up here to move my C and D. And I'm going to move my D line. We get 100% disclusion right here, meaning this is the only tooth touching. And so whatever happens between here and here, we would address, especially if this is a pain patient or a full mouth rehab or a full arch. You want to minimize all of this drag because that's going to be wear and tear as she functions, right? Or parafunctions. So again, where's our first tooth contact? She starts out right in the center, right? So the forces are coming together all at the same time, but she quickly deviates to the left, okay? And she'll sustain that pretty good. And when she starts to make her movement, instead of going, up to this point or up to this point to give anterior guidance, she's actually discluding off of her molars. That's no bueno. Oh, and she's also got a non-working interference. So down here on the time graph, total force graph, what you'll see is you can see that she's got a posterior interference on the left and the right when she's going towards the left. You see that down here, and by taking the cursor and moving it from right and left, you see what's in play in real time. So, if I'm going to correct her bite, this is probably the buccal incline of the palatal cusp of 2, or the buccal incline of the palatal cusp on probably 31, or it might, 31. So you can adjust from either one. And then here, you're looking at the palatal aspect probably of the palatal cusp as she's her lower jaw is moving towards the left. So you'd make a couple of little revisions there because she can get anterior guidance. You just got to get the interferences out of the way. So this is how I kind of work through my cases, especially if I'm putting porcelain in, making sure things aren't overloaded. And one thing that a lot of people don't really talk about is all of this data changes. If you've got porcelain or an all-on-4 or a splint or whatever in a patient's mouth, it's a good idea to check this once a year. You start with a baseline like we did today, and then as you make revisions or you add restoration to the patient's mouth, I check this once a year on all my patients, either where I'm doing a complete adjustment, or I'm changing VDO, or I'm moving teeth with Invisalign or whatever. It's a great service for patients. And they start asking questions like, well, how come you're the only doctor that knows this? And that's a fun conversation. But you actually build a lot of value with your patients when they realize that what they're feeling, you can see, and TScan allows a bridge of communication between the patient and the doctor that Blue Dots just doesn't convey at all. So, Shane, is there anything that you want me to address, or Stephen, before I leave this?
Yeah, I mean, I think it's, I want everybody to kind of think about what questions they want to ask as well too. Before we go into that though, why don't you talk a little bit about how or where you use TScan in your practice and why you use it there?
Sure. Well, I find the deeper you go down the rabbit hole, the more you're going to use it. So about 2 years ago, I started scanning every single patient, every new patient that was coming into the practice. And that gives another opportunity to discuss treatment options with patients. So imagine not doing a perio probe or not taking x-rays. You would be limited in what you could see or diagnose with the patient. And I get the feeling, and I just speak of myself randomly, that before I started using TScan to the level I am now, a new patient would come in and you would check out, okay, first molar occlusion, angles class 1. You would take a note of the overbite and overjet, look at midlines, and then you never look at it again. Maybe you make casts and you mount them, especially on a big restorative case, or you're changing BDO, or you're doing ortho. That's all good. But when do you compare that again? When do you look at it again? Really never. So I started doing the scans on every new patient that comes to the office about 2 years ago. And I don't really treat any kids in my practice, but once kids get to the 16 to 18, they start coming over from the pedodontist office, and you've got a lot of kids who had their decay taken care of, had their cleanings done. They may have had ortho, then they just go back into the hopper, the hygiene hopper, where they're seen twice a year. Nobody's checking occlusion. And I was seeing some really crazy things. And as someone who treats TMD and dysfunction, as it relates to occlusion, like, how many of these patients that we're seeing that are 40, 50, 30 years old really started the precursorship when they were in their teen years? And I don't think dentistry can answer that question because nobody's measuring. So I use this as a baseline, and then we also start talking, especially if I'm coordinating, like, this tooth number 14 with recession on either 14 or 19. Then we start talking about, rebalancing the bite. I use this anytime I'm doing inserting a crown, anytime I'm inserting bridge work, cosmetics. I already mentioned ortho, full mouth, and a full arch. I can't imagine not having this this technology. And if you're doing implants, you better make sure that you're not overloading these implants. There was some data that came out that 180 microns is enough to start to cause peri-implantitis in the absence of inflammation. You're losing bone and you don't know it. The hygienist doesn't know it. The patient doesn't know it. And then you get down, you take an x-ray, and you lost 50% of your bone height on that implant. Well, I'm sorry, Mrs. Jones, you must just have perio there. And meanwhile, Mrs. Jones doesn't have perio anywhere else in her mouth. It's just that implant. Yeah, bet you dimes to dollars it's overloaded. So This also, once you start talking about it, patients also come back to it. So I've done a number of, kind of a functional rebalancing with patients who are the crown of the ear club, who says they can only chew on one side. They're not in any pain, but over the course of having some crowns be, PFM, some are gold, some are cubic zirconia, they've got amalgams in there, composites. Those all wear at different rates. So it's not uncommon that a patient, we haven't even talked about, sleep disordered breathing. Throw that into it with a 300% more clinch, and you're really opening up Pandora's box. But this gives you kind of levels the playing field, right? So that's where I'm using TScan, and I'm probably using it more than a lot of other TScan owners. But it all occurred to me once a patient told me, I inserted 2 single unit crowns on her, and she said the bite was perfect and I didn't need to do any adjustments. And so when somebody says the bite is perfect, I'm like, well, let's take out a TScan and let's see what perfect looks like. Lo and behold, the patients cannot tell you. They can tell you if it's grossly off, but they have a really hard time telling you, hey, you know what, it's close, but it's not really there. And the TScan solves some problems too when patients come back and say, oh, it's hitting really hard. No, it's not. It is touching, and we want that tooth to be loaded, but it's not overloaded. So, and lastly, I would say that my remakes from fractured porcelain or cracked cosmetic like Emax has gone way down. Not that I had a real problem with it before, but it's always that that excuse that, oh well, the lab messed up. They, something must have been going on in the lab that day. Mrs. Jones, we'll just cut that off. We'll remake it for you at no cost. Meanwhile, the lab's been making your crowns for the last 30 years, and they do a very consistent job of satisfying your criteria. Otherwise, you wouldn't use them. You'd use somebody else. So usually it's something we left, usually a working or non-working interference, probably a working interference that caused that porcelain breakage. Did I answer your question, Shane?
Yeah, no, that was perfect on there. And we did have a question where somebody asked how much space does a digital data take? Stephen kind of answered that. It really doesn't take up a whole lot of space. I'm not sure the exact recommendation the company recommends, but you would have to have a lot of data just to get a gigabyte or a couple gigabytes of space on there, if I remember that correctly. But it doesn't take up much space at all.
That's true. It's nothing like a CBCT sitting on your server.
Yeah, or a
Not
photo.
even.
Yeah, I mean, there's a photo takes up way more space than a recording does on TScan. So I think we can open it up to now any questions anybody has. So like I said, you can unmute yourself and ask a question, or you can ask a question in the comments section. So we'll give you guys a second to ask questions.
Oh, we didn't talk about ROI.
Oh yeah, let's talk about that while they're thinking about their questions.
Yeah. So in the first 6 years that I had TScan in the practice, my ROI was about 0 because I bought it and I used it like I think most doctors do, which is for big cases only in cosmetics, and didn't really use it as ubiquitous as occlusion really is represented in a dental practice. And so I don't bill for, it's just part of my exam, so I don't bill for it there. Where I do bill the patient is if something like this shows up and we're going to do some restorative, This is like going to the tire shop in your town, and you need 4 new tires, and they're like, well, hey, Mr. Sutter, do you want us to do the alignment because these tires are wearing unevenly? And they're like, no, just put 4 new tires on there. It's like, okay, but I've told you that you have uneven wear, and anything that we put in there is going to wear just like your teeth. So, well, let's talk about that for a minute, and then all of a sudden the conversation changes. So it's good to have this fixed proactively before you start your restorative portion of your treatment or your periodontal portion of your treatment. So what do I charge for that? I charge a crown fee to do it, and I give three visits to get it dialed in. So from a business standpoint, a crown fee for 3 visits, but the 3rd visit, I actually start treatment. So before I get the patient numb, I'll take this out, make any little quips or minor revisions that I want, and then I'll start doing fillings and crowns and that kind of thing. So, the ADA says, I think that they somehow calculated that a patient is worth $1,200, a new patient is worth $1,200 or $1,500 on average to a practice. Well, that's talking with, patients regarding decay and periodontal disease. And so you're cutting out 1/3 of your available treatment option with the patient. And nowadays with Crest commercials and white strips, and people have a pretty high dental IQ that, hey, I should have a clean twice a year. Nobody's talking about occlusion. So when you see recession or uneven wear, it's always good to have that conversation and have the TScan out. Don't just take it and hide it, but just like you go through and you're talking, you're pointing at, an abscess that might be on tooth number 30 or decay that's on tooth number 6, you point to it and you tell the patient this should be the same thing. It allows you and the patient to have a discussion about something that they can't see. They may be able to feel it, and you might be surprised at how many doctors they've been to try and fix that one tooth that was put in, that one crown that was put in 7 years ago. So my ROI the last 6 years since I was trained on using TScan, it's added about $100,000 worth of treatment to the office per year. That's 6 years in a row. I think it's like $624,000 over 6 years. And your initial investment is what, 10? Like, I would make that investment every year if I could. And the other thing that I'll add is you're not just pulling treatment out of thin air. I mean, we know in every single book on occlusion, interferences are bad. You want force to be, distributed evenly over teeth, and no one tooth should bear the brunt of the force, like tooth number 14. In this bite, she's almost got 30% of her bite. If you don't treat this, this is your next crown, this is your next root canal, fracture, and there's no lab fee with it, right?
Correct. So we did have a question that popped up, and I don't know if you use any codes. He's asking, what code are you charging TScan under?
If I use what?
What code are you charging the TScan under? I'm guessing insurance code.
I'm not charging TScan as a code, but if I'm doing a functional rebalancing, I'm charging the code complete occlusal adjustment.
Okay.
It's like 9951, I think, or something like that. I'd have to look it up.
Yep. And we have some codes. If you guys want some codes to see what other dentists are using, we have some codes that we can send you as well too. I think that's one of the codes that's in there. Another question is, what benefit statement are you using to sell the treatment?
What benefit statement?
Yeah.
Yeah. So a new patient, okay, so Ashley comes in she's a new patient, and you know, I usually use the verbiage of cars, you know, especially like an 18-wheeler. So, you know, big trucks have a huge amount of force, and those forces got to be distributed evenly pretty much around all 18 of those tires. Now, in looking in this case, you know, does this look balanced to you? And of course, the patient's going to say, no. What are they going to say? What else can they say? And so the follow-up question is, well, okay, so if you have more force on some tires than others, then you're going to wear through those tires faster. Is that fair? And of course, the patient will say yes. And I'm like, okay, well, to make sure that the tires were evenly, I would check the alignment, I'd balance the tires, and that is actually going to it will avoid dentistry from an occlusal standpoint. It won't do anything for perio or well, it will do something for perio secondary to occlusal trauma, but it won't do anything for decay. So when you talk about high dollar stuff like, you know, needing a root canal or a crown because repetitive strain injury has damaged this tooth right here, you mean if I do this procedure, I won't need a root canal and a crown on that tooth? Well, yeah, that's what I'm saying. You get to avoid some dentistry by being proactive instead of being reactive. Now, look, if you go to Subway and you get an olive pit in your sandwich and you bite down on that, all bets are off, right? I don't think any of us can prepare for that. But we're just talking about checking something that's functional and it's easy to fix and balance. And I think there's a huge value to that. I mean, I do a lot of these where patients aren't in pain because patients just being educated, and everybody wants to avoid, you know, future dentistry.
Very cool. So another question is the way to correct the problem always reductive, or do you do additive also?
And it depends is the answer. So let's say, you know, like tooth number 4, if it didn't have any contact to it, yeah, you could put a centric stop there to kind of balance things out. But then you also have to manage that. You have to manage that filling. And you also get to charge the patient for the filling. I try not to add unless I absolutely have to. So, like in this case, we know she couples to the left. We know she couples to the right. We just have to get rid of a couple of interferences, and this thing's going to be back moving like a smooth operating machine.
Cool.
Is that fair?
Yep. I think that's perfect.
I guess you know what? Let the patient decide. Hey, there's 2 ways we can do this. We can add, we can take away, or we can do a combination of both. I'll tell you from doing it both ways, especially if we're talking about adjusting dentistry, I don't want to have to add, because then you got to get the patient numb. You got to, you know, cut in some retention. You can't just drop a dab of composite on a crown. I'd rather just get the crown that somebody else did adjusted, or maybe you did 20 years ago, you know, and balance it out that way.
Yep. So I don't see any other questions right now, but we'll kind of wait to see if any questions pop up. Do you want to share your information as far as, you know, your email, maybe some of the courses that you do, as well as some in-office training opportunities?
Sure. So let me just see. Can you see the PowerPoint slide?
I just see it. So you have to probably unshare the current slide and then share your PowerPoint slide.
Okay, hold on. Can you see that?
Yep, I can see that now.
Okay, perfect. So this is my contact information here. Be patient with me because I get about 100 emails a day. Probably 60 of those are spam, and 40 of those are, you know, doctors, friends, other people that have questions in regards to a case or in-office training or the DTR course. So there's basically, you know, you don't become exceptional at anything by going to a didactic course. TScan, and think about to your preclinical days. How many preps did you cut before you actually felt competent that you could cut a crown prep in, you know, in 15 minutes? It took a while. So TScan is not hard, it's not challenging, but it's correlating the adjustments that need to be made with the bite paper marks with the technology that you're seeing, the data on the scan. And that takes a little bit of training, a little bit of repetition, but it doesn't take much before you grab a hold of it. So if you're wanting, you know, some good, just, hey, I don't want to treat the patients that you treat. I don't want crazy, you know, difficult pain patients that are scary. And that's fine. You shouldn't have to treat those if you don't want to. But the principles, the occlusal principles on a bite splint or a DTR really are very, very close to what you're going to be doing in your occlusal adjustments on asymptomatic patients. So if you're like, hey, I just want to be a better doc with my restorative, with my implants, with my cosmetics, I'm happy to come to your office and work with you for a full day. And by the end of that day, you will be comfortable with TScan. The other thing to do is to come to one of the digital occlusion seminars courses, which you can find at this website, Digital Occlusion Seminars, you know, upcoming courses. The next course is going to be April 30th, May 1st in Las Vegas in 2021. And the second course is going to be held in Houston, October 1st and 2nd. And yeah, again, just click on upcoming courses at this website and it'll take you and you can register for those. If DTR is something that you're interested in and you want to treat those kinds of patients or become even as highly proficient as possible, then you definitely want to have Robert Kirstein in your office. It's invaluable training, and that's how I got comfortable with the clinical application of what TScan brings to the doctor, is with the repetition of seeing a couple of patients, 3 or 4 patients a day. Robert came in, and I think by the second patient, I was like, yeah, just hang out. I'll come get you to come look at the scans when I'm done. And he's very patient. He's very knowledgeable. So again, my contact information is right there. You can also find me on Facebook, Ben Sutter, DMD.
Perfect. And also, I want to share, if you don't mind unsharing your computer, I want to share the contact for the reps. If someone wants to talk to any of us reps, let me pull it up real quick. So if you have any questions, you know, that you want to talk with your reps, whether it's just a question about TScan, maybe you want to add TScan before the end of the year or get an idea of what some pricing are, here's a list of the reps. So the US, there's 2 of us. There's myself, Shane Varga, and there's also Stephen Moniz. I cover the Western region. So if you go Wisconsin and down south to LA and west, I cover all that area. The rest of it is Stephen's territory. Andy is the international sales manager for the Europe, and Don Delgado covers pretty much everywhere else internationally. So he's definitely a world traveler out there. So if you guys have any questions, you want to ask us some questions as well, here's information. So I'll leave that up there for a minute. There was one question that came in, and it is there a particular thickness of articulating paper that mimics the thickness of the sensor?
Yeah, the sensor is, I think, 100 microns. It gets down to about 80 microns when it's compressed, but I use 20 micron Parkel. So the correlation between the thickness of the sensor and the bite paper is not relevant. You want it to be thinner because you're going to have less false positives, I think. And let me just, one last thing before I go, because I need to go. I need to go pick up my daughter. I'm not being paid by TScan to do this. I'm doing this for free for everyone, and I'm doing it because I believe in the product. And after using the product for a decade, hands-on as a clinician, come to the realization that doing dentistry without it it's just not up to par. It's not up to par. And you don't know that until you actually have it and you start using it. I'm always surprised by what the patients tell me versus what I measure, and I do it in that order specifically, so I get the feedback from the patient, and then I figure out what's really going on. So I think every dentist should be using TScan. I've seen so many cases and fixed so many bites where just fillings were done. And you can see some of those on the YouTube channel, but it's heartbreaking. And dentistry is iatrogenically causing some of its own problems. And that's a fact. So
Awesome.
you guys have a good Merry Christmas, Happy New Year, and I'll talk to you guys soon.
Yeah, thanks, Dr. Sutter. And just so you know, this has all been recorded. So I want to thank everyone for coming to listen to us. I know people all over the world that decided to join us today. So we'll give you guys a link to the recorded version if you want to watch it again. Thank you.
Thank you all. Anthony, you got to get to work.